Good. This is going to be a very quick overview of the latest surveillance data on the STIs listed here. I've included quite a few slides that I thought you might find useful when looking at the presentation after the conference, because I'll have to move quite quickly through these to make the 15-minute limit. So I'm starting with gonorrhea, but just note that the gonorrhea and chlamydia data that I'm presenting here is from the lab-based surveillance. So that's where all laboratories in New Zealand report all positive, actually, and negative test results for both gonorrhea and chlamydia to ESR. So there's been a significant increase in the national rates in recent years since an initial drop after we introduced new data processing methods in 2013. That was when we, because we had the access to the NHIs, we were able to remove duplicate tests done within what's considered the episode period. So that's 3 weeks for NAT testing for gonorrhea and 10 days if it was culture. And for chlamydia, 6 weeks. And we also had all DHBs on board, so that we actually had much better data than we had in previous years. Now, the national rate does mask some important variations, which I'll give some examples of now. So one is that the male rate for gonorrhea nationally is greater than the female rate. This has been true for many years. In 2016, there were 98 cases per 100,000 for males, compared with 66 for females. Gonorrhea rates also vary quite widely geographically, with the highest rates historically in Te Rāwhiti, Hawke's Bay and Lakes DHBs. So this is showing trend data from 2012 to 2016. And then the Auckland region comes in after that, followed reasonably closely by Waikato in recent years. Now, interestingly, there are some areas in New Zealand where the female rate is higher than the male rate. Those are the grey areas on the map. And the DHBs with the highest rates from the previous slide actually have higher female rates. So that's Te Rāwhiti, Hawke's Bay and Lakes, which is a very different picture from many of the other DHBs or regions. And I think it's of interest to note that the difference is particularly marked in Auckland and Wellington, where you've not only got quite a disparity between male and female rates, but you've also got high case numbers. Now, gonorrhea rates by age, when we look at both sexes, all age groups between 15 and 39 years, we have far higher rates than the total national rates, as you can see from the figures here. Oops, sorry. Can I get backwards? Oh, yeah. Where's my little red thing? Oh, this one. Right. So this is 400 cases per 100,000. Remember, the national rate's 98, and for women, 66 in 2016. And here it is, it's about 300 for males in 2016. And that's in the green, which is the 20 to 24 years. And for females here, we're sitting at about the same level for the 15 to 19-year-olds, which is far higher than the national rate. And the trend has been that it's been increasing in recent years, particularly in those high-risk age groups for both sexes, 15 to 19, 20 to 24, and 25 to 29. For females, 25 to 29, not as high. Now, if we look at just male gonorrhea rates by ethnicity for those 3 highest risk age groups from 2013, this is a complicated slide, you can look at it later, but The highest rates are in Maori and Pacific across all three of those age groups in the past 4 years. But I think it is of interest to note that the rates, while they're lower in European and Asian, they've shown an increasing trend in both the 20 to 24 and the 25 to 29. So that's for Asian, for European. Whereas in actual fact, the Maori and rate has shown a downward trend apart from the 25 to 29. So there are some differences that are showing up there. If we look at female rates, they're also highest in Maori and Pacific in these age groups, but the trend across all ethnicities is generally stable, apart from an increasing rate in European females aged 20 to 29 years. 20 to 24 years here and 25 to 29 years, but the numbers are quite small here. If we look at the sites of infection for males, it is noteworthy that the percentage of all positive tests due to anorectal and throat specimens has been steadily increasing. So here and here. Don't be put off by the urine going up. That's just the change in testing from urethral swabs to urine. They almost mirror each other. So I think that the take-home message to me, or one of them from these past few slides, is that collecting data on sexual behaviour and activity as part of the new notification system, which will be happening soon, will be useful to help us start to understand what's happening with males and gonorrhoea, because it's vastly different from what we see with chlamydia. And perhaps mirrors a bit more what we're seeing in syphilis. So for chlamydia, the national rates have shown a small but significant increase in the past 2 years. In contrast to gonorrhoea, the 2016 female rate, as is true for most years, is more than double the male rate at 899 cases per 100,000 males, just under 400,000. The chlamydia rates by age group and sex, similar to gonorrhoea, the highest risk age groups are 15 to 19, 20 to 24, and 25 to 29, and that's for both sexes. But note that younger females do have much higher rates than males. This may be to do with who gets tested more often. We have far higher testing rates in females than males. And our testing rates for gonorrhoea and chlamydia, if we look at all the negative tests, are very similar to each other. So I think most people are getting both tests done at once, but much higher testing rates in females. Looking again for males at the site of infection for chlamydia, similar to gonorrhoea, there's been an increase in the percentage of all the specimens that are positive that are coming from the anorectal site. So again, here, not as dramatic as in gonorrhoea, but it's there. Not much change in throat though. Infants continue to be affected. No big change in the numbers there. Which one were you holding up? Oh, I'm sorry. I was looking at the top. Okay. So now I thought before I moved on to syphilis that we'd have some sort of light relief with the good news story, I think, about HPV vaccination. And I've actually gone back to 2009 and looked at the change because the vaccination program came in 2008. So we've pulled it from 2009 to 2016. We've got a decrease of 63.5% in first presentation case numbers. This is looking at sexual health clinic data. During the same time, there was a non-significant decrease in clinic visits by about 0.6%. So I think that is definitely a real change that we've got there. If you look at the figure at the bottom here, the most significant Decreases were seen in females aged 15 to 19 years, that's the red line, and then we've got the pale blue as females 20 to 24, but I think it's pretty great. Here we've got males going down aged 20 to 24 and 15 to 19. And they were much more significant changes than in older age groups, which I think fits with the Australian data and what we would expect from the vaccination program. Just got my pages out of order here. Right, so moving on to syphilis, which is not a good news story. So this is data presented that comes from the enhanced surveillance program that collects questionnaires on cases diagnosed in sexual health clinics in New Zealand. ESR's been collecting this since 2013, but we have access to the Otago AIDS Epi group data from 2011 and 12, but we couldn't reconcile it with all the other sexual health clinic data only from 2013. So we've had a really big increase again here. This is provisional, but we don't think it's going to go down. So we're up to about 320 cases last year with it. By place of diagnosis, again, similar to last year, our big problem, really most of this increase is driven by the Auckland region, but we've also got this increase in Waikato showing from last year as well. Canterbury's interesting because Wellington's gone up, but is just starting to approach a bit more with the numbers that you see in Canterbury. Now that may be partly to do with who uses sexual health clinics in those places. So you have to keep that in mind, and once we have notification data to add to this next year, this will be interesting to see if that sheds any further light on that. Looking at age groups, then the most striking increases up until last year had been seen in the younger age groups in recent years, the 20 to 39 years. That's 2012 to 2015. But there's been a significant increase in 2016, not only in these age groups, but also in the 40 to 49 years and the 55 to 64 here and here. But, you know, this is pretty dramatic down here. Sexual behaviour, as expected, I think the biggest increase is in men who have sex with men. But again, the trend we saw last year in heterosexuals, orange is males, grey is heterosexual females, has continued as well. So this is not confined to being an MSM problem. Right. And the percentage of cases reported as MSM has been relatively stable with a recent bit of a downward trend for it. By country of infection, again, most cases are infected in New Zealand. Sorry, I thought I'd gone to the wrong slide. And the percentage of MSM infectious syphilis cases reported as HIV positive has not changed in the last 2 years. We look at the context leading to infection, then the sex on site venues and use of mobile apps seem the most common context leading to infection, but there is missing information for most cases. And I question whether it's useful to actually attempt to collect this as part of the notification process, because if we're going to get that much missing information, you really can't analyse it, and there may be a better way to be collecting that kind of information. And last slide, primary reason for testing in 2016 for MSM, about 50% have clinical symptoms or suspicion, but you also have quite a bit of asymptomatic screening, whereas when you look at the heterosexuals, there's not very much asymptomatic screening. There's a bit of contact work, and I do wonder if we should be promoting more asymptomatic screening. for syphilis. Thank you.